3 seconds, and then away you go.
Okay, good morning, everyone. My name is Johannes Ansell Poh, and I would be presenting my master's research project, which is generating synthetic planning CT from diagnostic CT using deep learning to expedite palliative radiotherapy. I would like to thank my supervisors, Dr. Jim Rodrick and Joel Noble, for your supervision and help toward my project. I would like to start my presentation by giving you a bit of statistics. So in Australia, there's quite a significant percentage of palliative radiotherapy courses, which is shown by the statistics by the Australian Institute of Health and Welfare, where 40% of all radiotherapy courses in Australia in 2018-2019 were palliative. Also, the median waiting time before the start of treatment is longer in Western Australia at 14 days compared to Australia at 10 days. This is important, especially for palliative patients, where the main purpose of treatment is to give them pain relief and improve their quality of life. So, ideally, we want to treat the patient as quickly as possible in a way that's as convenient as possible for them to improve their quality of life. The standard radiotherapy treatment workflow is that the patients will come in for a diagnostic CT. If the patient needs to undergo radiotherapy, then they need to come back to the hospital for a separate planning CT. Then they need to wait for the treatment plans to be generated on the planning CT images. And after that, they come back to the hospital for the radiotherapy treatment. The purpose of this project is to remove the need for the patient to undergo a planning CT and instead generate synthetic planning CT from the diagnostic CT, so the patient doesn't need to take that extra trip to the hospital for the planning CT, which is especially important for palliative patients living in remote areas that have to travel long distances to the hospital. The reason why we need a separate planning CT instead of just using the diagnostic CT is the different couches used in the two scans. So in a diagnostic CT scan, usually a curved couch is used for patient comfort, and in planning CT and radiotherapy treatment, a flat couch is used for patient setup reproducibility. So if the treatment plans are generated just on the diagnostic CT images instead of the planning CT, then the patient cannot be treated with a flat couch. There are some literature available on simulation-free radiotherapy, or SFRT. This refers to radiotherapy that doesn't require the patient to come in for a planning CT. The first method of doing this is adaptive radiotherapy, where the treatment plans are generated on the diagnostic CT images. Then when the patient comes in for the treatment, the plan is adapted based on the images taken during the treatment. This potentially increases the treatment time because they need to update the radiotherapy plan before they can treat the patient on the day of treatment. The second way is to directly use the diagnostic CT scans. The problem with this is that we usually require the patient to be treated on a curved back blacks to mimic the curvature of the diagnostic CT couch, and that can result in a more difficult patient setup, which can also increase the treatment time. And the third way of SFRT is to generate synthetic CT from diagnostic CT, which is what my project is aiming to do. This reduces the time to the start of treatment because no planning CT is required, and also there is no need to adapt the treatment plan or use a back during the treatment, which reduces the treatment time as well. The dataset I used for this project includes 66 diagnostic CT for planning CT pairs from 58 patients. This is further split into training and testing sets. The training set has 56 scan pairs, which is further split into 5 folds for 5-fold cross-validation. And the testing set has 10 scan pairs. This project is an extension of a previous master student research project, Joe Noble, who is also my supervisor for this project. The dataset I use is the same as the dataset he used for his project, so the pre-processing has been done by Joe. For the rest of this presentation, I will use the term RDCT or rigid diagnostic CT as the input to the model. The dCT of the deformed diagnostic CT is used to refer to the diagnostic CT that has been registered into the planning CT, and this is used as the ground truth instead of using the planning CT as ground truth. This is done so that the model can more easily learn the deformations. And also the deformed synthetic CT of the SCT is used to refer to the output of the model. Initially, I tried using diffusion model to generate the synthetic CT images. The diffusion model works by starting with a pure Gaussian noise and iteratively removing the Gaussian noise from the image until we get a noise-free synthetic CT images. The results for this diffusion model, however, is not really good. For example, in this image, I did a lot of experimentations. For example, for this one, it doesn't produce a realistic looking CT image. For this experiment, it generates a very pixelated CT image. I tried generating the images slice by slice. It generates some promising looking CT images, but fails at others, and it doesn't have very good continuity between the slices. And also, I even tried using super resolution on the pixelated image to generate a higher resolution CT image. And also, it sometimes produce good looking images, but in other images, it fails to generate the details. So after talking to Jake and Mubasha and Du, we suspect that there's not enough images in the training set to properly train a diffusion model. So what I decided is to move to GAN or generative adversarial networks. I trained the model to output deformation fields and use this deformation field. Apply this deformation field on the diagnostic CT image to generate the synthetic CT image. GAN works by having a generator and a discriminator. The generator generates the images and the discriminator tries to discriminate between real and fake image. So the generator is trained by having the dCT as input and it outputs the deformation fields. These deformation fields are then applied back to the dCT image to generate the dSCT image of the synthetic CT image. And the synthetic CT image is fed to the discriminator for the adversarial loss. Other loss terms are also used, like the bending energy loss to ensure smooth deformation fields, and also comparing the synthetic CT to the ground truth images with Huber loss, dice loss, and other loss functions. The discriminator is trained to discriminate between the synthetic CT images generated by the generator and the ground truth default diagnostic CT or dCT images. This is the architecture used for the generator. It is a unit that consists of residual blocks, bottleneck blocks, and unconvolution blocks. And the final layer is a convolution layer with 3 channels, which represents the deformations in the 3 directions, X, Y, and Z directions. This uses the residual block, bottleneck block, and convolution blocks that are used in the GAN architecture, the generator architecture. And this is the discriminator architecture that is used, which is just a series of convolution layers and residual blocks with spectral normalization for easier training. The results for the GAN method looks very promising. This is the qualitative result comparing my synthetic CT to Joe's synthetic CT, the diagnostic CT, and planning CT. As you can see, it manages to make the posterior anatomy more flat than the diagnostic CT, and it also looks better than Joe's synthetic CT because this uses, by using deformation field, I'm able to maintain the resolution of the original diagnostic CT images, whereas in Joe's project, he generated the CT images directly, which makes it more blurry and has some artifacts. These are more results on the images, comparing the ground truth dCT images to the predicted dSCT images and the difference between the two. And these images also show a good flat posterior curvature. I did the analysis 2 different ways. One is padding back to original size with a lot of background voxel, and the other way is removing those background voxels to focus more on the CT images themselves. These are the evaluation metrics calculated on the images after padding back to original size, comparing my synthetic CT to Joe's synthetic CT and the diagnostic CT. Firstly, for the mean absolute error, mean squared error, structural similarity and depth measure, peak signal to noise ratio, and rule absolute squared sum of differences. It looks like Joe's model slightly outperforms my model, but my model still performs better than the input region diagnostic CT. And comparing the dissimilarity coefficient between my model and Joe's model, you can see that my model performs better than Joe's model in the dissimilarity coefficients. and also a bit better than the input rigid diagnostic CT except for the spine. This more metrics for this one is calculated before padding back to original size to focus more on the patients themselves and remove the background voxels. For this metrics, my model outperforms the rigid diagnostic CT images on all the metrics, and Joe didn't calculate the results this way, so I couldn't compare my results to Joe's model for this one. I also did some uncertainty analysis on the images. Because I trained the model with 5 volts cross validation, I end up with 5 different models, and I can use an ensemble learning, an ensemble prediction method to predict the synthetic CT images, and I use the standard deviation for each voxel to create the standard deviation for each voxel between the 5 different predictions to generate the uncertainty map. And as you can see, the uncertainty correlates to the difference between the synthetic CT images and the ground truth. So this looks pretty good. I also compared the dose on the synthetic CT, comparing it to Joe's model, the diagnostic CT, and comparing that to the ground truth time CT. I would like to thank Dani and Milad for doing those calculations for this section. The dose differences in this section doesn't really show that my model outperforms the models of the diagnostic CT. It looks like all those 3 CT scans have similar performances under those. And this is the GUI I made that compares the deformation on the diagnostic CT with the ground truth rigid diagnostic, the ground truth deformed diagnostic CT, and the difference between the two. In conclusion, the evaluation metrics show improved performance for my model for the dissimilarity coefficients for the different organs compared to Joe's model, but there's no improved performance on the other metrics, and also the dosimetric analysis doesn't show any improved performance, but it still shows clinically acceptable results. And despite the dosimetric analysis not showing any improved dose calculations, the main advantage for my method is that there is no need for planning CT, so the process is as convenient as possible for the patients, and there is also no need for adaptive planning and using feedbacks during the treatment, which reduces the treatment time. A bit of future work, more robust uncertainty quantification can be done. So I did some readings on uncertainty quantification, and it might be better to use a scaling factor to scale uncertainties for different regions of interest, so that we can get a single uncertainty value for the image that represents how clinically acceptable the image is for the given application. Another future goal that can be done is to predict the HU value changes from the diagnostic to planning CTs. So the HU values for the planning CT is standardized, but in diagnostic CTs, it can vary a little between different scans. Predicting the HU value changes using a separate network can potentially improve the dosimetric results and make it more accurate. And these are the references. Thank you for.
Thanks, Ansell. Well done. Questions for Ansell from the room? Any? Yep.
Did you compare the results of your model against different scanning sites? So you had pictures up of your thorax versus a scan, say, of your pelvis.
Okay. So I didn't compare based on the different treatment sites, because I only have 10 images in the testing set, which is not enough to compare the different treatment sites. I just do like the entire testing set, each image. Yeah.
Thank you.
Thanks, Ansell. That's great. Yeah, so I mean, to compare the quantitative analysis with the dosimetric analysis, I mean, how much stock or faith can we really put in the quantitative metrics if it doesn't seem to correlate to a dosimetric difference? And also the quantitative metrics are somewhat comparable, but then looking at it qualitatively, the image quality is clearly superior when you use the deformation field. So are they actually that helpful or meaningful, or should we just stick with qualitative analysis and dosimetry?
Yeah, the qualitative analysis with the looking at the image quality is a bit important because it makes it easier to define the boundaries between the organs. And also I talked to Brani about this, and he said that the automatic contouring that he used for generating the treatment plans is struggling with the blurry synthetic CT image, but it works for my synthetic CT images with deformation fields. So the qualitative image comparison is also important. And for comparing the evaluation metrics with the dosimetric analysis, the evaluation metric is for the entire image, and for the dosimetric analysis, the differences will be focused more on the regions of interest. So that might be why it doesn't really correlate, because the evaluation metrics will include regions that are not that important for the dosimetric analysis.
Yeah, that makes sense. So maybe a more targeted quantitative analysis would be more appropriate.
Yes.
Yeah, sounds good. I do have other questions, but yeah, okay, yeah. Just I was keen to discuss the dosimetric comparison. So it's all pretty comparable between my synthetics, your synthetics, and the original images.
Yeah.
But there's obviously differences between the images. So what competing factors do you think are at play to account for it all just sort of smoothing out and them all being comparable?
Sorry, what
What competing factors in the images do you think could be accounting for this overall comparability in dose?
What competing factor?
Yeah, like differences in the images. Like the original diagnostic.
So between my image, your image, and the diagnostic
Yeah.
CT image.
Because they are different images, but then
Yes.
why is the dose so comparable, I'm wondering?
I'm thinking because the images are very similar. So the different treatment sites in my image with your image and the diagnostic CT image will be roughly the same position. So the dose to that position will also roughly be the same. And in the end, the dosimetric results will also be similar. Does that answer your question?
Yeah, I mean, I think seems to go. Yeah, it's interesting. I mean, it also makes me think that perhaps the different weight distribution, particularly if it's mostly adipose tissue, isn't as significant as it may seem. When you're actually beaming through just a lot of fat, it doesn't actually have as much of a bearing on dose as you may think. Perhaps something like that as well.
Thanks, Ansell. Well done.